you. Once again, welcome to the teaching class of Department of Urology, Savai Man Singh Medical College, Jaipur. Today we have a class on renal tumors, on its classification and etiology. Will be presented by our resident, Dr. Saurabh Garg, and will be moderated by our faculty, Dr. Ajayraj Hada. So I request Dr. Saurabh to kindly share his presentation. Go ahead, Saurabh.
Good morning, everyone. I'm Dr. Saurabh Garg, SMS Urology Department Resident. I'll be starting my presentation on benign and malignant renal tumors, etiology and classification.
Share your presentation. Full screen, please.
Yes. Okay, so I'm starting my presentation on benign and malignant renal tumors, classification and etiology.
Full screen.
References are taken from
full screen, please. Dr. Sudeep is not there with you?
Yes, sir.
Yes, go ahead.
Yes, sir.
Go ahead. You don't have to start again. Yes.
Contents include renal cysts, oncocytoma, angiomyolipoma, papillary adenomas of kidney, metanephric adenoma, cystic nephromas, leiomyomas, and hemangiomas. These are the benign lesions of kidney. So, introduction includes among suspected renal carcinoma cases, 20% of the resected masses are benign. As per the AUA guidelines, recognized renal mass biopsy may have a role in decision making for small renal masses, which have shown to potentially reduce the need for intervention in significant proportion of patients. Now, most common benign entity encountered in the kidney are renal cysts. Up to 10% of the population may harbor them. Risk factors are age, male gender, hypertension, worsening renal function. They may be sporadic, acquired, or genetic in origin. Renal cysts may have varied causes. For example, the kidneys of the patients with AD, PKD increase in size exponentially over the time. Also, there are some sporadic renal cysts which increase in size and number over time, with an average growth rate decreased with increasing follow-up. So, what do? We do imaging studies in simple cysts. USG is done. It suggests that they have smooth walls, sharp outlines, absence of internal echoes on. CT and MRI, they show the absence of enhancement when we get the contrast. So there's a classification called BOSNIAK classification. It is 1, 2, 2F, 3, and 4. There are 5 grades in it. BOSNIAK classification 1 is a simple cyst which have a thin wall and does not contain any septa, does not enhance, no solid components, no calcification. In BOSNIAK type 2, there are few hairline thin septa, fine calcifications are there, uniformly high attenuation lesion less than 3 centimeter. Whereas in 2F, there is more than 3 centimeter, and that is why the incidence of malignancy is 18%, and we need to have a repeated follow-up for such cases. Then BOSNIAK classification type 3 is intermediate cystic lesions. They have irregular walls, they have septa, they have measurable contrast enhancement. That is 33%, and they need active surveillance, query / ablation. Type 4 are clearly malignant cystic masses, and the risk of malignancy is 92%. They may need excision or ablation. BOSNIAK 2F lesions they have are stable patients, and then we have to do a repeated follow-up. These are some renal imaging in which we can see that there is a right side kidney BOSNIAK cyst is present in the mid pole, and then we have a gross specimen of the same tissue. Now, management is based, I have already told the management for 2F, we have to do repeated follow-up, and for 4 BOSNIAK type, we have to do an excision. Now, if we go into genetics, there are chromosomes involved. There is a rearrangement of 11q13 cyclin D1, and there is a syndrome BHD associated with it. It is autosomal dominant. Folliculin gene on chromosome 17 is responsible for pulmonary cyst and cutaneous fibrofolliculomas, etc. In the pathophysiology, in the gross, the mahogany brown surface is seen similar to renal parenchyma, and there can be a scar, central scar that can be present. Histology suggests strongly eosinophilic cytoplasm with high mitochondrial density. Oncocytomas can be associated with perinephric, perirenal fat invasion and renal vein invasions. They carry a prognostic significance, but in RCC, but not in oncocytoma. Now, there are some IHC markers we can do for diagnosis, and these are the gross specimen of a bivalve renal oncocytoma demonstrating the renal scar. We can see the central renal scar in it, and there's a histopath image below. On evaluation, there's a hypervascularity and a central scar on axial CT imaging, and there's low positive predictive value of 67% for oncocytoma on renal mass labs. Then comes angiomyolipoma, also known as Dravet's, associated with Dravet's dysmorphic blood vessels, smooth muscle, and adipose tissue. The causes can be sporadic, genetic, associated with tuberous sclerosis complex, more common in female, and that too in 4th and 5th decade. Now, pathophysiology includes mutation in TSC1, TSC2, and inactivated mutations of these proteins result in unregulated mTOR activation that results in angiogenesis. On pathology, on gross appearance, it appears well circumcised, tan, pink, yellow surface, depending upon fat content. And on histology, vessels are seen because there is angiomyolipoma, that is vessels, muscles, and fat. Vessels are thick-walled and eccentric with spindle cells around the vessels. Now, the diagnosis is primarily done by USG and CT. CT shows the presence of intralesional fat, -15 to -20 HU, and MRI also suggests the same, that T1 fat suppressed sequences are seen. These are the images of CT scan and MRI. On the right-hand side, we can see a CT image with the upper polar angiomyolipoma with hypodensities. This is the management. And then we come to papillary adenoma of kidney. It is a low-grade, well-circumcised cortical lesion measuring less than 0.5 centimeter. Risk factors are age, male sex, and stage renal disease, acquired renal cystic disease, sporadic RCC, hereditary papillary RCC. On histology, we can see the uniform cells with benign nuclei. They are arranged in either in tubular or papillary or tubular papillary form. It's a pre-malignant condition, and papillary adenomas are associated with papillary RCC in 47% of the cases. It is often diagnosed pathologically. Then comes metanephric adenoma. It is more commonly seen in females, that in 5th decade, associated with flank pain, gross hematuria, palpable mass, polycythemia. On gross, it appears as well circumcised tan brown masses that can go up to even 15 centimeter. And on histology, it has scanty cytoplasm with SCNR or follicular or tubular papillary structures associated with WT1 and CD57 IHC markers. On CT scan, there is enhancement, which is uniformly less than that of the renal parenchyma. It is a finding in contrast to RCC. It is a CT image in which we can see a large metanephric adenoma in a middle-aged woman. Mixed mesenchymal and epithelial tumors. Cystic nephroma and mixed epithelial and stromal tumors, that is MESTs, are a group of tumors that are separate but genetically and morphologically related to benign lesions of kidney. Female predilection and frequent expression of estrogen and progesterone receptors is seen. Now comes cystic nephroma, more common in children in 2 to 3 years of age. Then because of the inability to rule out Wilms tumor radiographically, children should be managed as per the Children Oncology Group Renal Tumor Committee guidelines with initial radical nephrectomy. The key finding that differentiates a cystic nephroma from Wilms tumor is the lack of plastimal and embryonal elements in the resected tissues. Then comes mixed epithelial and stromal tumors. Perimenopausal women with history of estrogen replacement and peak incidence in the fifth decade are more commonly seen here. In men after a long-term hormonal deprivation for prostate cancer, it is seen. On a radiological examination, mests often appear as a complex cystic mass, such as BOSNIAK 3 to 4 lesion, similar to RCC. On gross, they can have a mean size of 6 centimeter. They're encapsulated solid cystic components that often extend into the renal pelvis. On histology, there are cystic components with cuboidal epithelium, and then they can be interspersed with a stroma of spindle cells. Estrogens and progesterone positivity is also seen, and mesenchymal markers such as vimentin, CD34, and desmin can be found. And epithelial components will stain positive for cytokeratin 7. Now, these are the axial CT images, a gross specimen images, and a histopath image of the same. Then comes leiomyoma. The renal capsule is the most common location, more common in women, and then small exophytic masses that are hypertense on non-contrast CT with hypo enhancement on intravenous contrast administration. Although this enhancement is less than that observed in the traditional clear cell RCC, chromophobe RCC tend to have hypo enhancement similar to leiomyoma, making it radiologically difficult to differentiate between two. On gross specimen, we see well circumcised and firm, and then calcification can be present, cystic generation can be there. On microscopy, it contains spindle cells that form intersecting fascicles without evidence of hypercellularity, pleomorphism, or mitotic figures. IC staining is notable for vimentin and smooth muscle markers, and we have to follow a nephron sparing approach. Then comes hemangiomas, more common in young and seen in sporadic types and associated with Klippel, Renal, Sturge syndrome, Sturge-Weber syndrome, etc. And renal anastomosis hemangiomas. They are also seen in mean age at 50 years of age with a male predisposition. Then I come to etiopathogenesis and pathology of renal cancers. Then on modern theory, renal cell carcinomas are basically adenocarcinomas and include a number of distinct subtypes derived from the various parts of the nephron, each with a unique genetic basis and tumor biology. Now, the types of RCCs are clear cells seen in 75%, papillary in 15%, then comes chromophobe 5%, oncocytoma 5%, and some collecting duct carcinomas less than 1%. Then comes the urothelium-based RCCs that include transitional cell carcinoma. Others are squamous cell carcinoma, Wells tumor, primitive neuroectodermal tumor, carcinoid, lymphoma, leukemia, and metastasis. Now, this diagram shows the cells of origin with respect to the part of nephron which is involved in the respective malignancy. Like we can see, the clear cell cancers or papillary cancers are more seen in the proximal part of nephron, whereas chromophobe or an oncocytoma are more related to the distal part of nephron, and collecting duct cancers arise from the collecting duct itself. Now we look at the etiology and environment factors of malignant renal tumors. The main established risk factors are tobacco exposure with a relative risk of 1.4 to 2.5, obesity, hypertension, and stage renal disease with acquired cystic disease of kidney, and hereditary causes. Now, some putative causes are lead compounds, various chemicals like aromatic hydrocarbons, trichloroethylene exposure, occupational exposure, asbestos, cadmium exposure, or radiant therapy. Even dietary factors may have some role, like high fat protein diet or low fruits or vegetable diet. Acquired cystic disease of kidney, like 40 to 50% of patients on dialysis will develop cystic diseases, and 5.8% of them develop renal cell carcinoma. As renal cancers arise with papillary hyperplasia of cyst epithelium. High proportion are papillary type tumors. Now I will be discussing some familial syndromes. The majority of cases of RCC are believed to be sporadic. Only 2 to 3% are familial. They include von Hippel-Lindau syndrome, hereditary papillary RCC, hereditary leiomyomatosis, renal carcinoma, Burt-Hogg-Dubé syndrome, associated with succinate dehydrogenase enzyme gene, tuberous sclerosis. Now, this image shows the various different types of malignancies and the typical appearances in radiology or histopathology or gross appearance, like in VHL syndrome. So, in VHL syndrome, we have typical pheochromocytomas associated with 18% cases. Then we have renal retinal angiomas. We have renal cysts. Then we can have cerebellar hemangioblastomas as seen in axial cut of brain. When we can have pancreatic islet cell tumors, endolymphatic sac tumors also. Now, VHL syndrome of RCC is seen in 50% of the cases, early onset and clear cell histology. It may be bilateral and multifocal, highly vascular tumors. Now, about the VHL gene that causes it, chromosome 3p25/26 is involved in it. Role, it is a tumor suppressor gene for both the sporadic and the familial clear cell RCC. Both alleles of the VHL gene must be mutated or inactivated for the development of the disease. Germline mutations of one allele of VHL, autosomal dominant inheritance, and the second allele is commonly lost by gene or chromosome deletion. VHL gene mutations are also in sporadic RCC. Now, VHL proteins, function of the VHL proteins to target the hypoxia-inducible factors and keeping the levels of HIF low. The HIF are intercellular proteins that play an important role in the cellular responses to hypoxia and other stresses. This is a compact flowchart that shows how the VHL gene mutation works. It forms the HIF proteins and how they lead to angiogenesis, affect the glucose transport, and affect the autocrine and paracrine growth stimulation. Now comes the familial papillary renal cell carcinoma. It also has autosomal dominant inheritance, multifocal bilateral papillary type 1 tumors, small vascular tumors, less aggressive than sporadic forms, and it's mostly 5th to 6th decade. There's a gross specimens on the screen and a CT axial image showing the hypodense lesion, which is a familial papillary RCC. Now, genetic locus is on missense mutation of the c-MET proto-oncogene 7q31, trisomy for chromosomes 7 and 17, abnormality on chromosomes 1, 12, 16, 20, and Y, seen in 13% of the sporadic cases also. Then comes the hereditary leiomyomatosis. Cutaneous and uterine leiomyomas are associated with type 2 papillary RCCs. It is solitary, unilateral, and aggressive. HLRCC locus was mapped to the region of 1q42, and this was later shown to be site of fumarate hydratase gene. Then comes the Burt-Hogg-Dubé syndrome. It includes cutaneous fibrofolliculomas that can be seen on the screen, then lung cyst, spontaneous pneumothoracis, and a renal tumor primarily derived from the distal nephron. Then we have chromophobe RCC, oncocytomas, and hybrid bilateral, multifocal, and less aggressive. BHD gene has autosomal dominant inheritance, and it can be mapped to the chromosome 17p 12q11. The gene product is folliculin, which appears to be a tumor suppressor gene. Now, on the left side, we have CT axial images of lungs having pneumothorax. Then comes succinate dehydrogenase gene associated with familial renal cancer. Bilateral RCCs, mostly clear cell RCC, but also type 2 papillary and oncocytomas are associated. Early onset, there is a head neck periganglioma. Few chromocytomas can be seen in this. Then we have tuberous sclerosis, which has autosomal dominant inheritance associated with facial angiofibromas, renal angiomyolipomas, bilateral and multifocal. Lymphangiomatosis of lung can be seen. Some neurological manifestations are there. TSC1 and TSC2 genes have been identified. Now, on the etiology of the same, we will discuss clear cell RCC, then papillary RCC, chromophobe RCC, collecting duct carcinoma, renal medullary carcinoma, unclassified RCC, and RCC associated with XP11 translocations. On the gross pathology, usually they are cortical tumors and round to ovoid and circumscribed by the pseudo capsule of compressed parenchyma and fibrous tissue rather than a true histological capsule. Most RCCs are not grossly infiltrative, with the notable exception of collecting duct RCC and some sarcomatoid variants. Most sporadic RCCs are unilateral and unifocal. Bilaterality is found in 2 to 4% of sporadic RCCs, more common in patients with familial form of RCC. Multicentricity found in 10 to 20% of the cases is more common in association with papillary histology and familial RCC. Now this is a image of clear cell RCC. Yellow are highly vascular. The yellow parts we can see are highly vascular. And the microscopically, we can see the histopath image of clear cell RCC. The cytoplasm is seen mostly clear. The septations that are seen are cell walls. Nest and sheet of clear cell with delicate vascular network is seen. The round or polygonal cells are seen. It is clear due to the glycogen and fat, and that is washed away from the cells. It can have granular cells with eosinophilic cytoplasm too. On papillary renal cell carcinoma, there is a tendency towards multicentricity, which approaches 40%. Type 1 papillary RCC, they are papillary lined by a single layer of cells with scanty pale cytoplasm, and it carries a good prognosis. Type 2 papillary RCC include potentially more aggressive variants with papillae lined by pseudostratified epithelium and eosinophilic cells, and it carries a bad prognosis, and it has abundant granular cytoplasm. Now we can see the difference in the histopath images of type 1 and type 2 papillary RCC. Then comes the chromophobe RCCs, well circumcised, homogeneous, tan tumors. This is the histopath image of the same. It carries faintly acidophilic cytoplasm. Then comes collecting duct tumors, consist of admixture of dilated tubules and papillary structures, typically lined by single layer of cuboidal cells. The cells we can see are of cuboidal in nature. Sarcomatoid differentiation, we can see the gross in the histopath image of the same. It is seen in the 1% to 5% of RCCs, most commonly in association with clear cell RCC or chromophobe RCC. Sarcomatoid lesions represent poorly differentiated regions of other histological subtypes of RCC rather than independently derived tumors, no longer recognized as a distinct histological subtype of RCC. Then comes the unclassified renal RCC. It features that remain indeterminate even after careful analysis are included in this. Most of the poorly differentiated are associated with a highly aggressive biological behavior, and they carry a particularly poor prognosis. So the summary is RCCs are adenocarcinomas arising from the tubular epithelium with clear cell and papillary arising from proximal convoluted tubule, and chromophobe and oncocytoma from the distal convoluted tubule. Sarcomatoid differentiation reported as areas within the other histological subtypes. Now, familial RCCs, renal cancers, are associated with bilateral and multifocal tumors with early age of onset. Molecular genetics have changed our understanding of RCC, and 7 associated genes have been identified. Understanding of VHL gene pathway has led to the development of molecular therapeutic approaches. Thank you.
A very good morning to all of you. So, renal masses, very important topic, both clinically and from examination point of view also. So, they can present as symptomatic masses or maybe asymptomatic. Right? The symptomatic masses, usually they can present with either a lump or pain or hematuria, or sometimes other urinary symptoms also. So mostly they are quite a big mass, which requires usually a surgical management. But now, because of the imaging studies, particularly ultrasound and CT done for other problems, we pick up these lesions quite often. So almost 50–60% of these lesions are picked up incidentally. That is why they are called incidentalomas. So renal lesion could be either a tumor, which could be a benign or malignant. It could be a cyst, which could be a simple cyst, or it may be a complex cyst. It could be vascular lesions like aneurysms, pseudoaneurysms, AV fistula, etc. It could be infective pathology, like sometimes there is a localized pyelonephritis, which is called nephronia.
Sometimes there could be a renal abscess. Sometimes even chronic infection like tuberculosis may present as tuberculoma, right? So these are the various presentations of various renal lesions. Now, because there are incidentalomas which are picked up quite early, we have a term called SRM, that's a small renal masses. Any enhancing solid tumor less than 4 centimeters size is called SRM. Right? So, how to manage these SRM is also very important. Usually, if SRM is less than 1 centimeter in lesion, the majority of these would be either benign lesion or some kind of indolent RCC. That is, they may not be quite virulent to cause metastasis or may not increase in size rapidly. So they are called indolent tumors. So most of them can be managed by active surveillance. Right? So how do you know that this is an indolent tumor and not a malignant tumor? Because minority of these could be even malignant with aggressive features. So you need to do a workup for metastasis. Sometimes these small renal tumors can produce metastasis, right? And then you look for the paraneoplastic syndrome, all the blood investigations and etc., which you look for paraneoplastic syndrome. If associated, then probably it may be a little more aggressive malignant tumor. So the tumors which are between 3 and 4 centimeters, they are majority, they would be more towards malignant. So they have to be managed in a sense that if the patient is clinically fit for surgery, we tend to do a nephron sparing surgery or any other surgery which we want in these patients. So tumors between 1 and 3 centimeters, usually, they have 3 options. One is active surveillance. Second is thermoablation. Thermoablation in the form of either cryoablation or radiofrequency ablation. And the third is a nephron sparing surgery. Again, this will depend upon a lot of factors. Factors like tumor characters, patient factors. So many of these patients who have low life expectancy are old, frail patients, or may have other comorbidities. We tend to manage them more towards active surveillance. If these patients are young patients, quite fit for surgery, right? And some of these tumors, the different tumor characteristics, like some may look infiltrative tumors. So that again goes more in favor of doing a surgical management. So this is how you manage all the renal lesions. And then again, one infective pathology which can mimic as a renal mass is the XGP, that is xanthogranulomatous pyelonephritis. So most of these are many of these tumors which can be diagnosed on imaging, like renal cysts, angiomyolipoma. And so these can be, the management can be chosen without further evaluation. Like a simple renal cyst, if it is a type 1 or 2 renal cyst, you will do only conservative management. If it is a pseudotumor, pseudotumors are hypertrophied column of Bertini. They may be congenital and sometimes they are acquired. Like if there is a scarring in the kidney, which could be traumatic, which could be iatrogenic, and that results in a compensatory hypertrophy of the adjacent renal parenchyma, which can appear as a pseudotumor. So pseudotumor, simple cysts, these are tumors which actually are managed conservatively, right? If it is a complex renal cyst, 2F or more than that, If it is an angiomyolipoma, which is bleeding or it's more than 3 to 4 centimeter in size, probably we will do a surgical manipulation. Though you can diagnose them on CT scan. Why? By the fat content. But then again, there are AMLs which are lipid poor. They may not be diagnosed on CT scan always. So these are the tumors which look like a benign lesions and may be managed conservatively. The rest of the tumors you have to evaluate further and try to find out whether they require what kind of management. So this was in brief about the renal masses that we can come across. So if you have any query, suggestion, ideas, anybody, residents, if we have some, Dr. Neeraj is there, Dr. Sanjeev there,
Sir.
Online. Yes, yes,
Sir.
Neeraj, would you like to say anything? Yes, go ahead.
Yeah. So as you said, we are diagnosing more and more small renal masses now by routine imaging for some other purposes.
Yeah.
So the challenge really lies in differentiating these small masses, which may be benign, from malignant masses. So
Exactly.
just wanted to ask Saurabh, so what are the radiological features of small benign renal masses which can mimic malignant RCCs?
Saurabh, come here. So would you like to answer this? How would you say that these SRMs would be malignant on imaging?
Yes, sir. We can do imaging studies that include CT scan, MRI. On that, we can look for the wall. So if the wall is smooth, thin, then it points towards benign lesions. If it is irregular, thickened, shows contrast enhancement, then we will look for think about malignancy. Then also we can also see the contrast enhancement of the thing. If it is a contrast enhancing, that also irregularly enhancing heterogeneous lesion, cystic lesion, it points towards malignancy. We can also look for calcification in the same lesions. Mostly calcified lesions are associated with malignancies. And the more the heterogeneity in the lesion, it will be towards malignancy. Also, the size of the lesion is also important. If it is more than 4 to 5 centimeter, we'll look for the malignant. It is a malignant mass. And then, sir, we can see for the vascularity. If it is more vascular, hypervascularity is there, and then it points toward malignancy. That's also
Correct.
Yes,
I think you said all those points correctly.
Majority,
There are
yes,
various
yes.
radiological features, but
Yeah.
a significant proportion of these, malignant renal masses may not enhance, or they may appear to be benign.
Yes.
So in those cases, now previously, the concept of FNAC was there, and it was said that FNAC should not be done in malignant renal masses because of the risk of tract seedling and all those things. But now I think FNAC is again being utilized in the diagnosis of small masses which are appearing to be malignant. So what's your take on that?
Yes, Neeraj. Biopsy has a role. FNAC, now we have a needle aspiration biopsy. Most of us would do a needle biopsy rather than
Biopsy.
because FNACB might be inconclusive in many times. So there is a role of biopsy, particularly in SRMs. And suppose if you are contemplating that the tumor could be lymphoma, then you will take it. We had a case of leukemic infiltration of the kidney. So these are some of these cases where a biopsy is probably required. Sometimes you find there is a primary lesion somewhere else and you find a small lesion in the kidney, or metastatic lesion in the kidney would require a biopsy. So all these patients would require biopsy. And then if you are suspicious of malignancy in a particular SRM and the patient wants it to be diagnosed preoperatively before you do a nephron sparing surgery, or the surgeon himself might think that it is better, it can change the management, then definitely you do a biopsy before going for any kind of management. I think these are probably some of the indications of taking a biopsy, particularly in SRMs.
Another indication, yeah, sorry. Another indication of biopsy, I think, would be in metastatic RCC. In metastatic
right, that's
RCC,
what I'm saying.
Yeah.
Exactly. If you think that it could be metastasis, there is a primary lesion elsewhere. That is one of the indications.
No, primary lesion in the kidney with widespread metastasis, in whom you are planning to put them on some sort of an immunotherapy or targeted therapy, just to confirm the histopathology of the primary RCC, a biopsy may be warranted.
Right. You are right. You are right. And another indication is if you want to go ahead with thermoablation, if you want to do a kind of cryo or radiofrequency ablation, usually you take a biopsy before you do a thermoablation. I think these are the indications for taking a biopsy, but you must know that there are complications related to biopsy. Also, the most common complication would be bleeding, right? Hemorrhage, bleeding, and sometimes it could be very torrential kind of bleeding, which may require even surgical management. So it's important to understand all these things. Anybody else has anything to say? Dr. Ajay? Anybody? No. Yes, Dr. Adi. Active surveillance. How would you do the surveillance in SRMs? What are the investigations and how frequently you would do the surveillance?
Sir, surveillance would be done in those cases who are not yet diagnosed, but the patient is presented to OPD with some symptoms. The symptoms that a patient may present to us is with he could have a pain abdomen, he could be having headaches or weakness, a loss of appetite, loss of weight. So after we get those symptoms, the first thing that we would like to do is USG. A plain USG abdomen would reflect a lot of things about the abdomen and the masses. USG would also tell us if there is a renal SOL or not, and if it is there, then what's the size, what's the location, if it's exophytic or endophytic, what polar region is it involving, the upper pole, mid and lower pole, crossing the polar lines or not, is it involving the...
The question is, how would you do the surveillance? You have already a renal mass there, so, right? So how would you do? How frequently you will ask the patient to come and investigate the patient? Definitely, if the patient has symptoms, he will come by himself, right? But how often you will call them? I think as far as we should in the first year, every 3 months at least, and we need to do an ultrasound at least, and yearly CT scan should be done. The importance here is how rapidly the size is increasing. If the size increases more than 5 mm per year, then it goes more in favor of malignancy. So if it is a rapidly increasing size, you need to tend towards surgical management in these patients, right? So that was the main question here. And then if you find on workup if there is some metastasis or a paraneoplastic syndrome appearing, and all these are important to know while doing the surveillance in these patients. Another thing which we probably missed is the genetic counseling in these patients, and how do we do genetic testing? So any young person less than 45 years of age, we should always think that it could be kind of a genetic problem. It could be a syndrome, like as I discussed, VHL. Then there is a syndrome, there is a hereditary renal cancer syndrome, right? So many of these renal cancers can go in families. So it's important to know that these patients can have this kind of, so young patients have this, then we need to counsel them. We need to have kind of aggressive surgical management in these patients. Anything else? Yes, Sudev. Yes. So Dr. Sudeep is asking, but as in prostate cancer, if the patients are put on active surveillance, we always do a biopsy. Is there a role of biopsy in SRMs particularly during surveillance? Yes. I think the indications for biopsy, as we have discussed, in active surveillance also, if you think the patient characteristics tends to dictate that, yes, we need to go for surgical management, we can take a biopsy. If it is rapidly increasing in size, we can take a biopsy. There is nothing like a routine biopsy. Every year, if you want to take a biopsy, that is not probably indicated. Definitely, if it is increasing in size, you either go ahead with doing a nephron sparing surgery or take a biopsy before. If you are going to do a thermoablation, definitely you take a biopsy, right? Anything else? So thank you, everybody. Dr. Ajay. I would request Dr. Ajay, our moderator today, to sum up and give the concluding remarks, please.
Hello. Thank you, Dr. Saurabh, for nice and informative presentation about the renal masses. And I would like to thank our esteemed guide and mentor, Siom sir, for valuable suggestions and guidance. Thanks.
Thank you, everybody. Thanks all the residents, all faculty members, and all those who might have joined us today on Zoom and YouTube. Have a good day.